Hi, Rajashri.
Good
Madam,
evening,
we are
ma'am.
live
Welcome.
now.
Welcome, ma'am.
Hello, Jairani.
Hello, ma'am. Hello, ma'am. How are you, ma'am? Good to see you.
Recovering, Jairani, after the knee surgery.
How are you, ma'am? How are you? I heard that you had a
meniscal injury. I'm getting better.
Madam, we are live now. Shall we start the program?
Yes.
Yes, sir.
So, good evening, doctors and all the participants. Shumon on behalf of Shield Healthcare, welcome you all in today's OGSSI Safe Motherhood Committee webinar on obesity and pregnancy. I would like to welcome the President, Honorable Secretary, and all the faculty members and dignitaries to this webinar. And let me introduce our today's MOC, Dr. Nithya Madam. Madam is the consultant obstetrician and gynecologist at Madras Medical Mission, Chennai, and she is the Safe Motherhood Committee member, OGSSI 2023. And in terms of special interest, Madam has keen interest in high risk obstetrics and reproductive medicine. So, with this short introduction, I request Madam to take over the session for further proceedings. Thank you very much, Madam, and over to you.
Good evening. Good evening, one and all present. I take immense pleasure in welcoming all the delegates and the faculty today. So here we are to know more about a very interesting topic on obesity and pregnancy. I would like to say a quote where investing in yourself is the best investment you will ever make. It will not only improve your life, it will also improve the life of all the others around you. Now, obesity affects every aspect of human being, from health to relationship and to mental concerns. So this is an interesting topic which was chosen for this month. So we have a lot of interesting topics for today. So before which it has always been our tradition to start our programs with Tamil Thai Vartha. Now we would like to have a lamp lighting before we step into the webinar. I'm very happy to welcome our Honorable President, Dr. Jairani ma'am, who needs no introduction. Ma'am will be delivering our welcome address today. Hello, ma'am.
Yes, ma'am.
Jairani ma'am is.
Oh, okay. Okay. Will you please allow Jairani madam in? She's saying she's not able to log in.
Can you see me now? Can you hear me now?
Yes, ma'am. We can hear you.
Okay. So it has been a great pleasure and honor to be here. And this is a Oxy webinar on the Safe Motherhood Committee. The chairperson, Dr. Rajashri. On behalf of Oxy 2023, I welcome one and all for this webinar on obesity and pregnancy. As rightly pointed out by Nitya, that obesity is a pandemic which is happening all over the world. And for a women, during this webinar, we will be talking more about their what are the complications that they go through during the pregnancy because of the obesity. So as a fertility specialist, we know that obesity has a great impact on the fertility and the fertility outcome. So it is always a mandate for all of us to understand the role of how weight reduction helps in the outcome of improving the morbidity and the mortality of the women's pregnancy. So I think it is a great initiative from Oxy to put into this obesity as a prime topic, and it is a very important one for all the clinicians to know about its impact on the outcome. So we have a lot of senior faculties here, Dr. Nimi Madam, Dr. Shanti Gunasingh, and Dr. Varani Vijayaraghavan, and also all other like Dr. Minu, who will be speaking on the perinatology, and all the senior people here to speak on the various aspects of pregnancy's impact by the obesity. So it's good to have you all here. I welcome you all, one and all, for this webinar, and I have a great immense pleasure on behalf of Oxy to welcome all the senior faculties, all my good friends, and also all the delegates, and a very special thanks to Sheil for giving us a platform to have this webinar. And I wish all of you a very wonderful webinar. Over to you, Nitya, for the continuation. Thank you.
Thank you so much, ma'am. Thank you for always supporting a lot of webinars and programs, which keeps us updating. We would now have Oxy prayer. I would like to inform Dr. Kundavi Madam, our secretary, will not be able to join us today. So Dr. Rajshri Madam will do the Oxy prayer. Over to you, ma'am.
Thank you, Nitya. Thank you, God. In humility we gather. In gratitude we pray for all the good things you have given us. Shower us with your blessings to pass on the healing touch, to celebrate the arrival of each new life and a mom reborn. The courage to deal with it all when things are not perfect, and to remember that we are but messengers to keep our women safe and free from sorrow. We bow before your kindness and the magnanimity of your endless love. Thank you.
Thank you, ma'am. We will now step into the first program for the day. So we will now have Dr. Barani, who is a member of a very enthusiastic member of Safe Motherhood Committee, Oxy 2023. She has been a recipient of award of outstanding performance in the maternal health care the year 2018, and also a best resident award from the Apollo Hospitals. We will now have Dr. Barani, who will tell us more about the pathophysiology of obesity in pregnancy. Over to you, Dr. Barani.
Thank you, ma'am. Good evening to one and all. I'm Dr. Barani, and I will be doing the first talk of this webinar today, which is the pathophysiology of obesity in pregnancy. Now, obesity, as we've all been discussing, has become a global epidemic now. The prevalence has tripled in the last 3 decades, and it has become a very important medical problem of women of reproductive age group. At least 30% of women in the reproductive age group are said to be obese, and 1/4 of the maternal health problems like GDM, hypertension are attributed to obesity. See, the inquiry into maternal deaths in both the United Kingdom and the United States of America revealed that at least 30% of maternal deaths in the last decade were due to obesity and obesity-related complications.
Bharani, you're not sharing your slides?
I am sharing, ma'am.
No, we are not able to see. Chitrakala? Suman, who's there?
Yeah. Are you able to see now, ma'am?
Yes. Make it slideshow. Done. Yes.
So 30% of maternal deaths these days are because of obesity and obesity-related problems. And especially as South Asian women, our cutoff for overweight and obesity is much lower. And our Indian women tend to have a higher abdominal circumference, which means the chance of developing obesity-related comorbidities is much higher in South Asian population. The HAPO study was done to find out what perinatal outcomes occur because of the various degrees of glucose intolerance in pregnancy. But an important finding of the HAPO study was that the maternal obesity becomes a strong independent predictor of adverse perinatal outcomes. Now, what our women generally think is they take pregnancy itself as an excuse to be obese. Our women think that I'm pregnant, therefore I'm becoming obese. On the contrary, the fetus, amniotic fluid, placenta, and breast hypertrophy are the main things that contribute to weight gain in pregnancy. Fat deposition in itself is only a minor contributor. But our women tend to gain excessive weight during pregnancy, and many women do not go back to their pre-pregnancy weight after delivery. This postpartum weight retention leads to a lot of problems in the future and in the subsequent pregnancies for these women. So what all problems can obesity cause during pregnancy? So even before a lady becomes pregnant, obesity can lead to infertility because of anovulatory dysfunction and adverse effects on implantation. And once the woman becomes pregnant because of excessive fat accumulation and high BMI, there are metabolic consequences like gestational diabetes mellitus, preeclampsia, hypertension, stillbirth, and a postpartum risk of maintenance of this obesity, and a lifetime risk of type 2 diabetes and cardiovascular complications. And as for the fetus, there are problems such as preterm birth, macrosomia, impaired fetal growth, hypoglycemia in the neonatal period, and the offspring becomes an obese person in the adulthood as well, with a lot of metabolic dysfunction. So how does obesity affect reproductive function? Obesity disturbs the HPO axis. So there's a shorter luteal phase. There are lower levels of FSH, LH, and progesterone. And this leads to a disruption in oocyte development. Also, the follicular fluid surrounding the ovarian granulosa cells seem to have an altered proportion of the insulin, triglyceride, free fatty acids, and inflammatory cytokines. All of this also contribute to the disruption in oocyte development. So obesity and pregnancy, these are the complications that a woman can face. There's an increased risk of spontaneous miscarriage, increased risk of pregnancy affected by congenital anomalies like heart defects, neural tube defects, and limb reduction anomalies, increased risk of GDM, hypertensive disorders, sleep disordered breathing, and prematurity, stillbirth, cesarean section, postpartum hemorrhage, venous thromboembolism, and anesthetic complications. We'll be looking into the pathophysiology of each of this, why each of this is occurring in pregnancy of the obese women. So there are some physiological changes which are common to both obesity and pregnancy. In obesity, because of a concentric hypertrophy that happens in obese individuals and because of fat deposition into the myocardium, there is already a left ventricular hypertrophy even before the woman begins her pregnancy. In addition to that, there is going to be an increased blood volume, cardiac output, and increased heart rate during pregnancy, which gets exacerbated in obesity, contributing to the left ventricular hypertrophy. And also some women have obstructive sleep apnea and pulmonary hypertension, contributing to right ventricular dysfunction. As a result of all this, women tend to have what is called as obesity cardiomyopathy. And these obese women are more prone for supine hypertension because of the increased intra-abdominal pressure. And this supine hypertension tends to occur much earlier in gestation. and changes in the respiratory system, there is a reduction in the functional residual capacity, which is much more in obese women. And also there is the closure pressure is much lower for these women. So there is a ventilation perfusion mismatch. There is a reduced oxygen saturation. And we know that pregnancy is a high oxygen consumption state. So these women tend to become hypoxic much earlier. And there is an enlarged breast and edematous airway. All of this contributes to difficulty during, in case of administering general anesthesia, there'll be difficulty in intubation and ventilation because of this edematous airway. There are two principal problems in women who are obese, which affects their metabolism. One is a systemic low-grade metabolic inflammatory state and a subclinical endotoxemia. This is there even before the woman becomes pregnant. And there are altered endocrine parameters, like there's an increase in insulin, increase in androgen, and increase in leptin. We'll be looking at the various endocrine factors that the adipocytes secrete. So because of these altered endocrine parameters and a low-grade inflammatory state, there's worsening of the insulin resistance, which is already there in later stages of pregnancy. As the pregnancy advances, women develop insulin resistance because of the placental hormones. There's worsening of this insulin resistance, and this begins much earlier in women who are obese. So what are these adipokines? Adipokines are these endocrine and paracrine factors secreted by adipose tissue. Adipose tissue not just acts like an energy storage organ, it also secretes these hormones. And hormones like apelin, ghrelin, leptin are all increased along with TNF-alpha and interleukin-6. They're all increased, and these contribute to the insulin resistance. They act like a primary stimulant causing insulin resistance. There is a protective factor called adiponectin, which falls in obese and pregnant individuals. This is a cardioprotective agent, and this falls. So as a result of all this, there is insulin resistance, a low-grade inflammation, endothelial dysfunction, alteration in the renin-angiotensin system, and there is also dyslipidemia. The HDL cholesterol falls and the triglycerides and LDL cholesterol increase. So there is an atherogenic state. So all of this contributes to the hypertensive disorders that develop in obese individuals. So because of the altered lipid profile and the insulin resistance, there's impact cytotrophoblastic migration, and compliance of the uterine spiral artery is reduced. There is placental ischemia and endothelial dysfunction, which really leads to release of anti-angiogenic substances and inflammatory factors into the circulation, a reduced level of nitric oxide, and an increased oxidative stress. All of this contributing to hypertension, proteinuria, and edema. So the chronic inflammation, there is increased interleukin-6 and TNF-alpha, and there's a basal fat oxidation, which contributes to increased LDL, VLDL, and triglyceride. All of these are atherogenic factors, and added to it, the endothelial dysfunction leads to preeclampsia. Now, how does obesity cause GDM? We all know that the insulin sensitivity remains unchanged in the early part of pregnancy, and insulin resistance develops later in pregnancy due to placental hormones. But in obese individuals, there is central obesity, insulin resistance, and atherogenic dyslipidemia. All of these are clustered ever since early gestational age. And these women appear to be insulin resistant from early on. So there is a threefold increased risk of GDM in these women. And there is an imbalance between protective factors like adiponectin. There is high levels of factors that cause insulin resistance like TNF-alpha, interleukin-6, HPL, and leptin. So the state of what is called as gestational diabesity prevails. As a result of this, women develop diabetes during pregnancy. Now, how does obesity cause venous thromboembolism? So we know that pregnancy is a prothrombotic state, and there is venous stasis in pregnancy. This gets exacerbated in obesity because even obesity is a hypofibrinolytic and a prothrombotic state. So the virtuous triad, which we know of, the stasis of blood flow, hypercoagulability, and endothelial injury, are all accentuated in obese individuals who are pregnant. So these women tend to be have a lack of mobility because of the obesity. The abdominal adiposity and elevated intra-abdominal pressure further restricts venous return. There's higher levels of fibrinogen and prothrombin in obese women, making them hypercoagulable. And the high metabolic activity leading to liberation of inflammatory substances heightens the endothelial dysfunction and promotes oxidative stress, endothelial injury, platelet aggregation, and all of this leads to venous thromboembolism. This is the reason why we have to take obesity as an occur during labor. So there is high levels of cortisol in pregnant women who are obese, and there is an alteration in the estrogen progesterone ratio. Because of all of this, there is pregnant women don't, obese women don't get into labor early, and there is a longer duration and a slower progress of the first stage of labor. There's some amount of insensitivity of the cervix to prostaglandin E2 because of the increased levels of leptin. And labor dystocia can also occur because of the fat deposition in the maternal pelvis, a fetal macrosomia, and an impaired uterine contractility that naturally occurs in these obese women. There's high chance of malpresentation, operative vaginal delivery, shoulder dystocia, cesarean section, PPH, perineal trauma, and an increased risk of subclinical genital tract infection, PPROM, endometritis, chorioamnionitis, and surgical site infection. Right now, there are no recommendations to say that we need to induce a woman who's obese just because there's macrosomia and there is a higher chance of stillbirth in these babies. But then we need to inform these obese individuals that they are at a higher risk of having an emergency cesarean section and having a thromboembolism and anesthetic complications, have them meet the anesthetist even before they get into labor so that we are prepared for the labor. Now, how does obesity affect the fetus? So there are a lot of prothrombotic agents which are increased in an obese individual, like plasminogen activator inhibitor 1, which leads to miscarriage. And this oxidative stress and the insulin resistance also leads to recurrent pregnancy loss. There is a folate deficiency in obese individuals, which can lead to neural tube defects, which is why we recommend that obese individuals be started on 5 milligrams of folic acid, which are increased dose than normal individuals. And there's a risk of GDM, and because of poor penetrance of the ultrasound waves, because of thick abdominal wall, there is more chance of us not detecting these congenital anomalies. And there is an oxidative stress and a pro-apoptotic state in these babies. As a result, there is high chance of development of congenital anomalies. And there's a constant availability of glucose, lipids, and amino acids to the fetus. So this contributes to macrosomia and childhood obesity. And gestational diabetes, hypertension, and placental insufficiency may lead to stillbirth in these fetuses. And the intergenerational effects of maternal obesity, we know that any mother who's obese or who has diabetes, the baby has a fetal as well as an early postnatal overnutrition. So all of this leads to a hyperinsulinemia in the baby. There is malprogramming of the neuroendocrine systems in the baby, leading to malregulation of the dietary intake, body weight, and metabolism. So there's a permanent overstimulation of the beta pancreatic cells. These children become obese children, obese adolescent, and ultimately obese adults. So there's a state of hyperglycemia, hyperinsulinemia, insulin resistance, impaired glucose tolerance, putting them at a risk for type 2 diabetes and cardiovascular diseases in the future. So the takeaways from today's talk is maternal obesity happens to be a strong independent predictor of adverse outcomes like gestational diabetes and hypertension. We need to have this in mind and screen obese women for gestational diabetes mellitus and hypertensive disorders of pregnancy. The physiological changes of pregnancy gets accentuated in obesity, and this insulin resistance and chronic inflammation seem to be the pathogenetic mechanism. Although these are the most common mechanism, we are not able to unify and see this is the cause for adverse outcomes in obese individuals. So more clinical research on mechanisms and interventions are required. But I think primary prevention to prevent obesity is mandatory. Thank you.
Thank you so much, Dr. Bharani, for the detailed, yeah. Sorry, you're on mute. Yeah.
Am I?
Yeah.
Thank you.
Thank you so much. Now, moving on to the next topic for the day, bariatric and metabolic surgery for morbidly obese women planning on pregnancy, when and what, by Dr. Raj Palniappan, sir. We welcome you, sir. Sir is a bariatric surgeon and an obesity surgeon, currently working at Apollo Hospitals, Greaves Road, Chennai. Sir is a specialist with over 400 successful bariatric surgeries, including sleeve band, diurnal switch, bypass, and retro bariatrics. Sir has been literally shaping all our lives. Thank you, sir. Over to you, sir.
Thank you so much. And thanks to Dr. Rajshri and Oxy for giving me the opportunity to speak about bariatric surgery. Having said that, I mean, in the introduction, you said more than 400. That must be a 10-year-old. uh, I think dead. I think so. We had crossed around close to 2,500 now. So, okay, having without much further delay, with a beautiful talk which has already been done by the previous speaker, I'd like to get into a little bit of a surgical option of obesity for women who want to get pregnant at the earliest, and to find out why and what can be done about it. So, is my screen visible to everyone?
Yes.
Okay. So when it comes to obesity, we all know that it's pathologically a big problem, really, with the multi organ dysfunctions, hormonal imbalance, and everything. But to go further, what to do when you get to that stage of morbid obesity? So maybe I will just brush again with what the previous speaker spoke about, a little bit of obesity and reproduction and why we do bariatric surgery then, and again what are the surgeries what we have, and is there can be any different procedure for obesity and different procedure for infertility as well, and their outcomes, and then pregnancy, what to do after surgery. So we all know in reproduction, as the speaker spoke, there are a lot of adipokine, issues that can hold on to so much of problems. Leptin increases, which inhibits insulin-induced ovarian, sterogenesis, and luteinizing hormone stimulated estradiol production as well. Adiponectin decreases, which increases the plasma insulin level. Restinin, which causes insulin resistance, and bisflatin increases, causing increased insulin sensitivity, and momentin decreases, causing insulin sensitivity, and then chemirin, which increases, causing a negative regulation of the FS. So plenty of this kind of a hormonal imbalance that happens, which leads to hyperandrogenemia, deterioration of the HPG axis, leading to PCOS and anovulation, hypothalamic hypogonadism, and again, infertility increases by 5% with increase of BMI after 29. So that's pretty alarming. Sometimes when the people become morbidly obese, there can be 70-80% chance of infertility in this kind of woman. And then miscarriage increases by 38%, which is the threefold. And after reproduction success reduced by 10 to 25% in this kind of obese patients. And that is one reason why we really look into weight loss in these kind of patients. Again, there's a very strong relation to gestational diabetes as well with obesity. Twofold increase when the patient is overweight, causing gestational diabetes. Fourfold increase when the patient becomes a little bit obese, and the morbidly obese people have a eightfold increase in gestational diabetes. Again, fetal macrosomia, it's very high, about 30% as compared to 11.6% in the normal individuals, and then larger than gestational age fetus, and postpartum complications are much higher. And you see the table column on the left hand side, the relative risk is pretty high the moment you tip over into morbid obesity. So 5.5% increased relative risk, and then all BMI of 46% incidence of gestational diabetes once they become morbidly obese. There are other issues as well. Preeclampsia, which increases 2 to 3-fold, hypertension, odds ratio of 1.8 per 10 kg, and increased incidence of first stage labor and cesarean section, leading to cesarean section, and intrauterine growth retardation of 8.1% against 0.9%. Again, the relative risk of eclampsia is in morbid obesity 6.5%. Hypertension is 27%, which is very, very high, and LSCS relative risk is 42% once the patient becomes morbidly obese. So that's which kind of a pretty much of a high range of hormonal issues to infertility. Once even when you get pregnant, chances of hypertension, eclampsia, gestational diabetes, and chance of LSCS are increased, which again increase the morbidity of the patient, and there are a few mortalities as well associated with it. And that is the reason why we contemplate bariatric surgery for patients needing pregnancy or who are morbidly obese, which can change a lot of things, which is going to come in the next few slides. Again, we see a picture of a lady who's morbidly obese, and then the same patient lost weight and then became pregnant again. Indication wise, Bariatric surgery is recommended for any BMI more than 32.5 with PCOD infertility and BMI of 37.5 without comorbidities for an Indian population. For a Western population, because they tend to get a metabolic syndromes pretty later, 35 and above with comorbidities and 40 above without comorbidities are the guidelines. But for Asian and Indians, it's come down by 2.5 BMI. And of course, there are few types of surgeries, restrictive surgeries like a band and a sleeve, and a malabsorptive surgeries like a Roux bypass, MGB, duodenal bypass. There are plenty of surgeries. Restrictive surgeries largely try to restrict the food intake alone, as well as some kind of a satiety and a yearly satiety and kind of a hunger reduction. That's a major part of a restrictive surgery. They have an indirect effect on the metabolic effect, whereas malabsorptive surgeries have a direct metabolic effect, which can be beneficial in the long run, especially when it comes with a lot of hormone deficiency in patients. And why we talk about bariatric surgery? It's the only proven long-term treatment for a morbidly obese when all others fail by 95%. And again, weight loss of up to 95% with a life, improved quality of life by 95%, which is a very, very high number. And again, the resolution of comorbidities also are close to 85-90%. So tend to really help ourselves in a big way. Again, resolution of reproductive issues, results are comparable even in, as comparable with the normal non-obese patients having pregnancy, and then improved risk benefit ratio are all the benefits. And when it comes to complications, a morbidly obese PCOS is about 46.8%. Post bariatric surgery, it comes down to 5.5%. That's a huge reduction in the risk of a polycystic ovarian disease. Infertility, threefold increase in morbidly obese and decreased by 60% in bariatric surgery. And again, gestational diabetes, 15.4% against 4.3 after surgery. Again, pregnancy-induced hypertension come down to 7.7 against 26%. Eclampsia 2.9 against 30% in 13% in a morbidly obese. And miscarriage comes down drastically to 7.8% against the 33% of the morbidly obese. Again, that's a almost 25% increase in the assisted reproduction success rate of 50.3, which is as close to a non-obese reproduction thing. And LSES is reduced by half, 20% against a 42% after in the patients who are morbidly obese. So plenty of advantages that helps them to make patients go as close to normal obese, no obese patients getting into pregnancy. So that is a big advantage what bariatric surgery can bring in. There are plenty of other hormonal alterations after bariatric surgery, from the hypothalamus to increased GnRH, and the pituitary increased LH and FSH as well. And of course, decreased whole cycle in the urinary metabolism and peak LH and the increased luteal PDG and decreased time of the PDG rise. All those things lead to some kind of a regulation to as normal as possible. In the adipose tissue, decreased insulin resistance and decreased estradiol helps in that. In the periphery, also it helps. In the ovary, there is a decreased MIS. Even in obesity, there is a decreased MIS, and post-bariatric also there is a decreased MIS. But again, this decreased MIS is seen much more in the people beyond 35 years of age. So MIS level is related to the age. Less than 35 of age, these people doesn't have too much of a reduction in the MIS that helps in Müllerian regulation. So that is why we always recommend bariatric surgery when the patients are pretty young and not after 8, 10 IVF or IUI failures. At the earliest, if you're morbidly obese and getting into bariatric surgery below 35 will help you to get much more better normal pregnancy rates. And of course, influenced by time of conception, post-bariatric, the longer the time duration you give, the better the results with all the hormonal changes. Especially if you give it beyond 18 months, you'll have the best results. And of course, the another issue what bariatric surgery can bring in the side effects is oral contraceptive pills have unexpected pregnancies increased by around 20%. So they always talk about either contraception by condoms or injectable was contraceptive contraception is recommended. And again, increased sexual function also helps them to be better as a couple post bariatric surgery as well when they are morbidly obese. And again, there are plenty of other advantages. As I told you, restrictive procedure, sleeve is significantly better over a balloon or a band, and abstinence is 1 year is good enough. So if the patient is a very, very high precious baby kind of a scenario where they desperately wanted pregnancy immediately, we recommend sleeve gastrectomy, because by 12 months abstinence, you can always get back to your pregnancy. And then 60% excess weight loss and 30% of weight regain is possible as well in later stage after 3 to 5 years. So typically, if the patient wants to be having a quick pregnancy and delivery, sleep is a beautiful procedure. When it comes to malabsorptive procedure, there are deficiencies of B12, iron, calcium, protein, and vitamin D. But the advantage is it can be tailor-made to different issues. Certain procedures have plenty of control of comorbidities. Certain procedures can be beneficial for PCOD infertility. So depending upon what are the things we wanted, it can be tailor-made. Again, the weight loss is very good, 80% excess weight loss and 5% reduction in the weight regain. I mean, 5% only chance of weight regain. That helps metabolic surgery to be much more long-standing. And again, if delayed beyond 2 years, nutrition becomes better and deficiencies are very, very less. With metabolic procedure giving a good excess weight loss of 68%, PCOD resolution of more than close to 90%, infertility resolution of 67%, all other comorbidities around 78 to 80%, with least surgical complications in a perfect hand, gestational weight gain of 6.6 kilos average, deficiencies of 26%, and a small gestational baby of 9.7%. It's pretty much very good to have a metabolic surgery over a restrictive procedure, especially when you have time in your hand when you're talking about bariatric surgery. So when it comes to bariatric surgery, there are 5 or 6 common procedures that are done. The most common of them all, sleeve gastrectomy, which is not one of my favorite, especially because of the weight regain chances. And I recommend sleeve gastrectomy only for people who are desperate to get pregnant at the earliest, where we do a omental dissection on the greater curvature of stomach and use a stapler and divide the stomach laterally and make a small banana-like stomach which has a capacity of 80 cc to 100 cc against a 500 cc, which is the original volume of a stomach. This helps to decrease the ghrelin hormone, which is secreted in the fundus of a stomach, and that's by invariably trying to increase the GLP-1 hormone and helps in satiety, weight loss, and insulin resistance comes down, helps in PCOD and infertility as well. But again, it's an indirect way of helping it. When it comes to malabsorptive procedures, the gold standard of a Roux-en-Y gastric bypass is where we create a pouch of 25 cc of stomach and a loop of 75 to 150 centimeter of jejunum is taken out and is bypassed so that food doesn't go into the distal stomach, which is about some 475 cc of stomach, and the first 150 to 200 centimeter of the small bowel, food doesn't enter. So the alimentary tract is shortened, the digestive timing is shortened, as well as the absorption is shortened in a Roux-en-Y gastric bypass. So this gives a much better result than a sleeve gastrectomy. But unfortunately, because of the size of a stomach pouch coming down to 25 cc, patient can't eat much. So there is a higher chance of these patients getting into a depressive state. Close to around 25 to 30% of these women go into depression, especially they have more like a pleasure eating before surgery. So a new addition called one anastomotic gastric bypass, a mini gastric bypass is added to this armamentarium, where we give a 80 cc stomach pouch, which is similar to what a sleeve has, and do a bypass to it, which is about 150 to 200 centimeters. So this gives a good eating capacity as well as a malabsorptive capacity. So it gives the result of a sleeve when it comes to eating well, but result of a bypass when it comes to malabsorption. So this is gaining popularity, and the most famous metabolic surgery in India and South America. This helps people to eat near normal, not near normal means like a diet person who's dieting. So they will be much more comfortable in accepting the eating habits as well as lose all the gain all the benefits of bariatric surgery by increasing the chance of pregnancy and and all the hormone changes. A recent addition of single anastomotic duodenal bypass is for people who are super obese. If you are more than 60 BMI, you are 160, 170, 200 kilos of weight, and you want to lose close to 100 kilos, 120 kilos, then you have a much more stronger procedure called single anastomotic duodenal, where again we create a sleeve, but do a very stronger bypass, join the duodenum to the ileum, and the entire jejunum is bypassed. So the malabsorption is much more stronger. With that, lot of problems of nutritional deficiencies also becomes higher. So if the patient is able to do a nutritional deficiency control by good supplementation, then this is ideal procedure for super obese. But we will not recommend this for simple, severe obese or morbid obese who are just 30 kilos, 40 kilos overweight. Recommended for people who are 100 kilos and more overweight. Another recent 6 years into the practice is single anastomotic sleeve jejunostomy. So sleeve ileostomy is similar to duodenal ileostomy. Jejunostomy is you do a sleeve and do a small simple bypass to the sleeve, which is gaining more popularity, especially for young women needing pregnancy. It gives a fast result like in a sleeve. So within a year's time, you can get into pregnancy because there is not much of a nutrition deficiency, as well as the big advantage is the normal alimentary tract of duodenum jejunum also is intact. So food enters to both through the normal digestive tract as well as through the bypass tract. So benefit of having a normal tract is there. So access to the hepatobiliary system is there as well. Plus deficiency of nutrition is not much. Again, it avoids the complication of a sleeve, of a reflex, what happens in a sleeve, which is very common. That chance of reflex is also very less. So this is gaining much more popularity for infertility treatment. In my opinion, single anastomotic sleeve jejunostomy is my choice for morbid obese people waiting for pregnancy, because within 12 months you can get back to pregnancy with a good nutritional support, and you have done about 80-90% of excess weight loss as well. And another procedure is a duodenal jejunal bypass, which again, it's much more for people with comorbidities. We don't do this much nowadays in our system. What exactly happens? We need to first understand what we call enteroinsular axis. So the ghrelin hormone, which is secreted in the fundus of a stomach, which triggers a group of hormones called anti-incretins. These are the hormones which are given in the black in the duodenum and the proximal jejunum, which is secreted in the first 80 to 100 centimeters of the jejunum, and the duodenum, against an incretin group of hormones, which is in white, which is secreted across the entire small bowel. When the anti-incretin increases more, it gives more resistance to the secretion of GLP-1 hormone. That GLP-1 hormone is responsible for insulin secretion, for satiety, as well as all the hormonal activity of ovarian hormones being active as well. So what happens is when there is more anti-incretin, there is more insulin resistance, there is more suppression of ovarian hormones. Post sleeve gastrectomy, ghrelin alone is removed. So there is a partial reduction of anti-incretin, and indirectly it helps to give you some kind of a good result. Whereas if you do a bypass, the anti-incretin groups are completely bypassed. So there is a very strong reduction in the anti-incretin factor, very strong increase in the GLP-1 hormone, which improves the insulin resistance and action, normalizes the plasma insulin and glucose, as well as improves the secretion of the ovarian hormones, early satiety, and this also helps in beautiful weight loss and resolution of ovarian issues. So it acts by foregut theory, where the ghrelin and acts where the majority of stomach is removed, nutrient pass rapidly into the proximal GI tract, which also reduces the appetite, weight loss, and improves glucose tolerance. The hindgut theory is the GLP-1 and PYY hormones secreted in the L cells and in the ileum most commonly. Again, it reduces the appetite, weight loss, and improves the glucose tolerance, and enhances delivery of nutrients to distal duct as well. By this mechanism, and the GLP-1 and anti-incretin mechanism, it improves or resolves a lot of diseases. diabetes 83% reduction, heart disease by 82%, hypertension by 92%, arthritis by 76%, GRE by up to 90%, and OSA by around 98%, bronchial asthma by 80%, non-alcoholic fatty liver disease comes down by 90%, polycystic ovarian disease is reduced by 100%, urinary incontinence by 88%, migraine by 57%, depression by 55%, gout by 77%, and venous stasis by 95%. And by this, the quality of life is improved by 95% and improves your life expectancy by 10 to 15 years. That's a huge difference what it can make, apart from helping you to get pregnant better. And we have a good series which we're going to come in the next slides to explain to you what are the benefits what we found in our department. Of course, since there is going to be a bypass or a restriction, there are a lot of nutritional issues that is going to be happening. B12, iron, calcium, protein, and some water deficiencies are pretty common because of them being very much absorbed in the stomach and the proximal small bowel, where the bariatric surgery is mainly done. So these deficiencies has to be tackled. Of course, if they can be tackled simply by means of a bariatric specific multivitamins, there is no deficiencies that will come that needs to be worried about. Major complication wise, there is a data by International Federation as well as our national data, a leak rate of 1.4%, which is pretty common, which is very, very, very rare problem nowadays. Stricture rate of 0.64, major bleeding of 0.47, especially the GERD and intestinal obstruction, which is a bit common, about 6 to 7%, with the overall complication of 11.21%. It's one of the safest surgery to undergo for the benefit what you're going to get. So data-wise, Indian data is much better than international data. A gastric surgery gives you a 17% complication, but a bariatric gives you 11.2% complication. And there is a misnomer when people say that bariatrics has a lot of complications. Unfortunately, it is false. It is better than a GA data. Mortality-wise, it's 0.4% with a GA data mortality of 3.15%. Still very, very less than a GA data. So one of the safest operation that can be done if done in the right hands. Coming to pregnancy after bariatric surgery, it depends upon the based on type of surgery. Surgical choice is based on the maternal age, compliance, and the waiting period. As I told you, if the patient wants to not want to wait longer, a sleeve or a sleeve with vaginal bypass is the best procedure. If the patient can wait, if they're not married or willing to wait for 1.5 years to 2 years, then directly going to metabolic surgery is the best choice in these patients. Ideal is pregnancy after 18 months. There is an increase in the maternal weight and with increased amount of time you have give. So beyond 18 months, the gestational weight gain can be as high as 8 to 10 kgs, which is good for the baby. And of course, comprehensive team is very important to have a nutritional assessment as well as the gestational period management by a good obstetrician. Quarterly nutritional follow-up is very important because deficiencies is pretty common, especially during pregnancy after metabolic surgery. And major complications of bariatric surgery is just 2.4%, so nothing major to worry about when it comes to these kind of complications. In our series, we did a study for almost 3 years with our patients undergoing bariatric surgery or metabolic surgery for PCOD and infertility. So we did 47 cases of sleeve gastrectomy, RVGB in 6 cases, and OAGB in 49 cases. With 102 cases, we have resolution of 85 cases from completely PCOD, which is 83%. Comes infertility, we have 12 patients from SG and 7 patients OAGB, total of 19 patients for infertility, and 16 of them became pregnant or conceived naturally, and artificial reproduction technique was used in one and succeeded. On one is lost to follow up, so we didn't know what happened to those patients. So it's a huge success rate what we can give from a resolution of PCOD and infertility by bariatric surgery if the patient is the right choice of patient. Again, incidence of fertility issues is 53%, infertility is 19, nulliparous women are 16 of them, and 3 of them are multiparous, where they became so obese and they couldn't get pregnant. And of course, trial of pregnancy is 33, infertility is 18, and PCO is in only 5%. So this is pretty good results when it comes to getting pregnant after bariatric surgery. When it comes to complications, we have a good gestational weight gain of 8.2 kilos against international standard of 6.6 kilos. So our patients, we can manage the nutrition pretty well, and 8.2 kilos. And then LSCS was pretty high in our series. We had about 42.4% LSCS series because most of the patients opt for LSCS post bariatrics. They don't want to go for normal pregnancy. Again, small gestational baby, only 4.3% against a 5.6% international series, and 4.3% is acceptable to a normal stance of 2.2 to 3% in a normal non-obese patient as well. Nutrition deficiency is in 26%, and GRD is in 39% of the patients, but all of them are managed by medications easily and with no major complications. We pretty much in our series have very, very higher rates of success with bariatric surgery. And of course, an average birth weight of 2.96 in all our babies, which is a pretty good considering Indian standards. One preterm baby, which needs to be, having some kind of a typical neonatal management done. There is no intrauterine growth retardation or anomalies in any of our single babies that is born. And that's a very good success rate, what I call when it comes to the baby as well. To conclude, bariatric surgery gives up to 85% excess weight loss, up to 90% resolution of comorbidities. Nutrition deficiencies are challenging, but if you carry out a bariatric specific multivitamin replacement, they are not a problem. And of course, the choice of procedures. If you do a sleeve or a single anastomotic stenostomy, pretty much no need to worry about nutrition. One anastomotic gastric bypass also tends to be a much good choice because they have a good volume of eating. People can eat about 150 cc of food in a OAGB, causing them not to have too much of nutrition as well. Of course, longer the time they wait, better the outcome of pregnancy, and small fall age baby is managed by adequate nutrition. However, close supervision in the peri-pregnancy period is very, very important. And of course, large studies for greater understanding of the hormonal changes and the effect of BS on pregnancy has to be understood. Thank you so much.
Thank you so much, sir. It was very impressive, and it's quite shocking to see the statistics as well. I'm sure there are a lot of doubts, and we would. So anybody having doubts can share it on the chat box, and during the panel discussion, we can have them answered. Thank you, sir.
Thank you so much.
So now moving on to the next topic for the day, impact of maternal obesity and gestation weight gain on the fetus through infancy, childhood, and adulthood by Dr. Binu Nanan sir. Professor Dr. Binu Nanan sir is a director of pediatrics and neonatology. Currently works in the MGM Healthcare, Chennai. Sir is a reputed teacher, administrator, and healthcare entrepreneur who has helped set up more than 10 neonatal units in India and in abroad. Over to you, sir.
Thank you very much. And I'll just share the screen now. Can you see it?
Yes, sir.
Okay. So, first of all, thank you, each one of the senior consultants there who have given me an opportunity to talk to all of you today. I see a lot of senior people who I know, so it's very nice to see all of you again. Thank you, Dr. Rajshri, specifically for inviting me in person for this. Thank you, Nithya, for the nice introduction. And I really loved listening to two talks by Dr. Bharani and Dr. Raj. I'm hearing Dr. Raj for the first time, and it was nice to listen to all the bariatric surgeries. But I'll talk about what I am the specialist on, and I'm going to talk about maternal obesity, the gestational weight gain on the fetus through infancy, childhood, and adulthood. The overview, I will be taking you through the obesity in children and the importance of the first 1,000 days of life, of which you remember that the 280 days is inside mummy, and then the maternal obesity and its effect on offspring. The proposed mechanisms, I just heard a nice talk about the pathophysiology, but we like to know how it happens in the fetus and the child also. And then we'll also talk about the limitations of the existing literature when we talk about does obesity cause such and such and such. So only some things are can be really proven. Rest of it is speculation. So as much as obesity is a problem for adults, obesity is a problem for children, and especially after the COVID, you remember that children are now becoming obese. They didn't have any activity to do. And if you look at the slides, you can see that it affects in the even for neurocognition with poor academic performances, and also because they have excess weight and risk of many non-communicable diseases. As you said, it is generational obesity that we worry about, and you look at the high disease burden. So you find that even just the activity of living is affected, especially with the mobility. Indian babies are at a higher metabolic risk due to their thrifty gene, so that you find that Indian babies are smaller in all anthropometric measurements, but with relative preservation of body fat. Thus, they are muscle thin, but adipose body composition. Therefore, if you're born in India, you naturally have a higher risk of metabolic diseases, which I think one of the reasons that we have become the diabetic capital in India. The early nutritional experiences with a risk phenotype, you'll end up with obesity, hypertension, insulin resistance, and then we'll end up with all the adult onset diseases. So we can see that early life nutrition is linked with the onset of metabolic disease in later life. The foundation of the lifelong health is built in early childhood. And when you talk about childhood, you can look at it from the preconception till here is your first 1,000 days. And that is your Barker's hypothesis. Anyway, much of human development is completed during the first 1,000 days. And this is when the most vulnerable period happens. And appropriate nutrition is an important factor. Certain reasons are there. One is that appropriate nutrition can be at different ages in adulthood, preconception, prenatal, early childhood, middle childhood, adolescence. Early life nutrition set basic foundation for lifelong health. Nutrition in early life can be linked to an increased risk of disease in adulthood. And most importantly, nutrition is one of the most easily modifiable environmental factor during early life. So, as somebody said, investing in early nutrition is a surefire strategy. The returns are incredibly high. We are talking about fetus overnutrition, then we are talking about postnatal overnutrition. Then we are looking at postnatal under and postnatal overnutrition. And as you can see, the most sensitive window in this picture is the prenatal, infancy, and early childhood. So when you look at the associations of maternal obesity, I'm not going to talk about the too much into the fact that being born into a family, mother who is obese, is likelihood that you are going to have a larger birth weight, you are likely to have a larger weight gain during infancy, you are likelihood to have a larger weight gain during the first years of life, you are likely to be an adolescent who is obese, and you are likely to be an adult with a problem. So in fact, we have looked at birth weights with preconceptional maternal weight and gestational maternal weight. Almost all the associations with childhood health is most commonly associated with the preconception maternal weight rather than the gestational weight gain, except the birth weight. Except birth weight alone has more to do with the gestational weight gain. Everything else is with preconception maternal weight. Early weight gain is a predictor for pediatric and adolescent obesity. Weight gain between birth and 12 months predicts BMI 36 months and 60 months. And the rapid weight gain during the first 2 years of life lands up with a 5 times increased risk of childhood obesity and a increased risk of obesity at the age up to 20 years. So clearly, the childhood obesity is related to maternal obesity. You have a baby who is born big and the baby continues to be big, and you are in an environment where you tend to have a different and altering lifestyle, and you land up with problems even in adolescence and adulthood. I'm going to talk about the other aspects which are not usually that we talk about. The type of delivery, I won't talk about it because we have already been discussed. Congenital malformations, as was pointed out earlier, the low-grade metabolic inflammation and the subclinical endotoxemia, which was mentioned. This lands up with endothelial dysfunction, embryogenesis, and therefore you can find that's a much higher incidence of spina bifida, neural defects, and congenital heart disease. All congenital heart disease, PDA, VSD, ASD, TGA, arch disease defects, and it correlates with increasing in weight gain. Each percentage increase has got a percentage increase in malformation. There is a much higher incidence of preterm birth, most often medical rather than spontaneous. And its complication. You have a preterm baby, then I don't need to tell you the amount of time that they separated from the mother, and also the complication that will happen because of preterm birth. There is increased respiratory complications. The common complications that we talk about, much higher incidence of TTN, one because of increased incidence of cesarean sections. Second, it's because of the fact that you are born to an infant of most often to infant of diabetic mother, because the diabetes is going to increase risk because of obesity. Also, it is supposedly because of alters of the steroid balance, and therefore you find that the TTN is higher. There is also an increased risk of respiratory distress syndrome. This is in keeping with that the fact the baby is preterm. Also because babies are born to gestational diabetic mothers. Also because it is apparently this insulinogenic condition that we are in suppresses surfactant. And the steroid dysgenesis also affects surfactant production. So all the reason you find that you have a child with a higher risk of respiratory distress syndrome. So increased risk of TTN, increased risk of RDS. These children have a higher risk of asthma in the first 1 year of life and up to 5 years of life. And there are some recent studies have shown that they have an increased risk of asthma up to 14 years, and now they are saying even up to 18 years. This is after separating out the fact could also be obese. Even after separating out this fact, it says that yes, the asthma risk is higher. So you have TTN, RDS, and asthma. And the fourth thing they talk about is because the children may be more obese, you have all the complications of obesity-related sleep apnea syndromes, etc., etc. Cardiovascular complications, structural heart disease I talked about earlier. We can also talk about increased systemic hypertension in these children, and bile is also abnormal in these children. There's also an increased risk of neurodevelopmental and mental health issues. Now, if we talk about what mental health issues can happen, the immediate understanding for us would be that if these children are going to be an obese mother, there's going to be a chance that they are going to be obese, and therefore they may have an increased risk of anxiety, depression, and as they grow through childhood, there's more chance of bullying, problems of school issues, drug abuse, all those. But it is not only that. We are talking about children who then land up with increased risk of ADHD, autism. These are also more common in these children. And overall, they say that even the overall mental ability is affected because of childhood. Then why does it happen? There are 4 things that they talk about. One is immunity and the metabolic effects, which are roughly the same as what we talked about in the maternal pathophysiology. The role of oxidative stress, which is because of the low-grade metabolic inflammation that goes on, and subclinical endotoxemia, which was highlighted earlier. There's a role of a microbiome. Obese tend to have a different microbiome, and this microbiome apparently is also passed on into the breast milk, also onto the placenta, and it's also there in the fetus. And these microbiomes have a role in neural development. So that's a big thing now they talk about. Very difficult to prove this. And in fact, most of the proof in microbiome is related to animal studies, not with human studies, but that is the big thing that now everybody talks about, the microbiome and relation to neurodevelopmental outcome. The last of it is something called epigenetics. So now that's the current in word now, everything is through epigenetics. So if you look at it, this is what they talk about. You have a genetic predisposition, you have a diet, and you land up with obesity. These are the 4 changes you're talking about: inflammatory changes, metabolic changes, hormonal changes, and an altered biome. All of it lands up with something called epigenetic changes, which may be permanent and transgenerational. So what is this epigenetic change? Again, as I said, genetics and environment and the microbiome, and you have changes in the epigenetics. Epigenetics is actually something I'll show you here. As you can see, this is a cell and you have a chromosome, and these chromosomes, a part of it which is expressed will be called the genes, which are wound around something called histones, and the amount of gene that is expressed can be controlled by external environment that you are in. This switching on or switching off is called epigenetics. So the gene is there, but whether it's going to be switched on or switched off is called epigenetics. I think that is one simple way to say is that the same cell is there both for your skin and your brain, because both of it comes from the ectoderm. But why does the skin become a skin and why does the brain become a brain? Because only part of the gene that is actually being expressed. And that control can be changed because of epigenetic markers. So now the current thing is nutrition, inflammation, oxidative stress, all of it changes the epigenome early in life. And this is where you have an altered gene, and that is there all through life. So it is not actually a gene modification, it is the expression of the gene that changes. That is what is the current concept of epigenetics in obesity. Now, one thing to remember is that all these studies has limitation, because there are only 2 types of studies you can do in genetics. You cannot do randomized control trials. You cannot do an intervention and see what happened, because these are studies which you have to carry on for 1 year, 2 years, 10 years, 15 years, 18 years before you get to a conclusion. So the most often the studies you can do is prospective cohort studies. You have mothers who are obese, you have mothers who are not obese. You have to look at the gestational weight gain. So you have already 2 divisions: maternal obesity with excessive weight gain, maternal obesity with not of the excessive weight gain. Then you follow them up through, and then you look at what happens to these children. Are the children going to be obese? Are the children going to have asthma? Are the children going to have neural defects? See, these are things that which are difficult to prove. A randomized trial, you have an intervention. Here, there's no intervention. These are all population-based observational studies, and you take a cohort and take it there. Or you can have a case control. You have a child with an ADHD, and you compare with a child who does not have an ADHD. You can go back historically and find out how many of them had mothers who are obese and who are not obese. So you can only calculate a relative risk, or in prospective cohort studies, you can give odds ratio and relative risk. So that is why you always say percentage. There is a 30% chance of an increased risk of ADHD. There's a 33% chance of an increased risk of asthma, because it's very difficult to disprove or prove. Now add on to the fact that if this baby is born into an environment where the mother has got obesity and the lifestyle that the family is used to, you'll find that this child is naturally going to be tending to be obese. Now, to tease out the obesity of the baby and prove it to the maternal obesity is extremely difficult. That is why there are limitations in this. Many of it are animal studies and then population studies, which we come to the conclusion. So in summary, maternal obesity leads on to intergenerational obesity. It has got association with complicated pregnancy, delivery, preterm birth, and neonatal complications. Associations with increased respiratory and cardiovascular illnesses into adulthood. Genetic changes through the biomes, oxidative stress, and inflammation appears to be the mediator. It is always not possible to pinpoint the causative association because of the limitations of what we are talking about. These are because of prospective observational cohort studies that we can do it. So thank you very much.
Thank you so much, sir. As always, it was very interesting talk. So the doubts will be clarified during the panel discussion. We are now moving on to the next interesting session for the day, a panel discussion on obesity and pregnancy. And our moderator for the panel would be Dr. Nirmala Jaishankar ma'am, who's the senior consultant at Apollo First Med and Apollo Cradle Hospital, Chennai. Madam needs no introduction. Sure, everybody knows ma'am. And ma'am, shall I introduce the panelist? Yeah.
Yes, Nitya.
Yes.
Yeah.
Dr. Shanti Gunasingh ma'am, our panelist, who is a consultant in obstetric and gynecology, who is a past president of our OGSI and a former HOD of Kilpauk Medical College and a former director and superintendent of KGH. Welcome you, ma'am. Dr. Karpagambal Saira ma'am, who is a consultant obstetrician and gynecologist and a fertility specialist.
Hello, everyone.
Hello, ma'am.
Yes.
Dr. Vanilla ma'am, who is an anesthesiologist from Apollo Women's Hospital, Chennai. Welcome you, ma'am. And Dr. Rajkumar Palniappan, sir, and our Dr. Binu, sir. Over to you, ma'am.
Good afternoon. Thank you, Nitya and Rajshri. When Rajshri asked me to moderate a panel on obesity, I thought obesity is very simple. But after listening to Bharani, Dr. Raj Palniappan and Dr. Binu, where they went into the epigenetics, like when I was planning to have coffee, I didn't have my bun with that, because after listening to all of them, I just had a plain coffee. And I would like to welcome Shanti, my dear friend, Karpagam. But I kept my panel very simple. I mean, I didn't go into all these the micro details of obesity. So I'm going to keep it very simple as a practicing obstetrician. And Dr. Binu brought out the nuances of conducting a study, because there are so many interrelating factors into obesity, and it is very difficult to draw conclusion. So I will just share my slides. Yes. Sharing the slide was my biggest nightmare, because every time I share it never happens. So welcome, and because we are already running short of time and all of us have to get back to our clinical practice, I'll keep it very simple and short. Now, we heard about all the panelists, how obesity is becoming a burden. We always thought developed countries like US are where the obese people are there. But now we know that even developing countries, it's becoming a problem. We heard from Dr. Bharani how 25%, 1/4 of the Indian population is overweight. And what we actually have to do it is prevent these overweight patients getting into obesity. So we heard that how it is becoming an epidemic because of the lifestyle and eating habits. Our India is a country of extremes. We have malnutrition in certain states and extreme obesity in the other. With this, Karpagam, I'm going to invite you, if you can rotate your screen so that we don't see you upside down. Yeah. We'll put it here so that. Can you just define obesity and overweight for us, Karpagam, so that we have uniformity? Because as an elder obstetrician, we always talk in terms of weight. We say she's 85 kg, she's 92 kg. Is that okay, or should we have a uniform way of defining overweight and obesity? Karpagam, unmute.
Yeah. Yes, madam. Good evening, everyone. It's always better to have a uniform standard criteria for defining any parameter. So for overweight and obesity also, we have to calculate what is called as body mass index. So the BMI is very, very important. So when it comes, we actually, from what is given in the guidelines, we Asians especially have a lower BMI range compared to the other Caucasians. So according to the classification, we have, when somebody, his BMI is more than 25, we call them as overweight. And somebody more than 30, we call them as obese. So actually, by Indian standards, even they have the cutoff as 18 to 23 in certain guidelines.
Actually, quite a few times, we relate more to the weight. It is like having a grade and a mark. It's like an A+ is at 90, 92. But then, as you rightly said, it's better we have a uniform way of, describing what is overweight and obesity. And Dr. Binu, he told the point saying that born in India, you're actually having a disadvantage of being a metabolically prone person for all the metabolic syndrome. That was something which was very, very new to me. And also, I would like to congratulate Binu. We read his name in the papers saying that he looked after a one-day baby with some tumor and things like that. So very nice to see all these senior people. Okay, Shanti, you're there, no? Our patient is a 35-year-old Mrs. Priya, married since 8 years. She is trying to conceive for the past 6 years. Her height 5'2", weight 84, BMI 33 kg per meter square. So she comes into a category of obese rather than overweight. She has irregular cycles, PCOS. Losing weight has always been a moot point. When she comes to the OP, you tell her, you can lose weight. And they tell us what they normally say, Madam, I'm trying, but I'm not able to. And all she could manage was to bring down her weight from 87 to 84 kg. Now, she has had hysterolaparoscopy as a part of investigation for infertility, has had many cycles of ovulation induction. She was not keen on IVF, finally and thankfully conceived with ovulation induction and IUI. Her fertility specialist has referred the patient back to you, Dr. Shanti. At 8 weeks, the scan showing a single live intrauterine gestation for antenatal booking. She is currently taking folic acid. Metformin was started empirically. Her glucose tolerance test was normal, but then she had a fasting insulin and hence she was started on metformin. And she is also on progesterone. Now, my question is, apart from the routine antenatal booking, would you do anything specific because she comes under the obese class 1 category?
Yeah. Good evening. I think everybody, this metformin has been put for her only just because she is PCOS or she had IgD.
No, only her glucose tolerance test was normal. But they did fasting insulin as a part of investigation, and her fasting insulin level was high. I would like to know from you and Dr. Karpagam, what is the significance of doing fasting insulin, and would you continue the patient on metformin?
See, I would not do a fasting insulin at all. I would, this patient is a known case of PCOS marching through pregnancy, obese. So for that, probably, although certain guidelines say that metformin should be given only for impaired glucose tolerance, probably it can be continued for some time, say maximum 16 weeks or 12 to 16 weeks. But then progesterone, I don't think I will routinely put. And this, she being quite obese, I will also do a vitamin D, which is also very, very important, vitamin D. And if she is deficient in that also, I would probably add that.
Karpagam, do you have any different take on metformin, considering that the metformin was started empirically? And because it's in the period of organogenesis, would you stop metformin and then probably do her oral glucose tolerance test early on, say between 12 and 14 weeks? And if it is abnormal, would you restart? Or would you continue the patient on metformin?
Yes, madam, I would like to say that, I mean, I'm not happy putting the patient on metformin if they have a normal blood sugar values. And as Shanti madam said, I routinely do not do fasting insulin levels, because insulin resistance is the pathological process that is going on in polycystic ovaries. So the manifestation of that, the clinical manifestation is impaired glucose tolerance or abnormal GTT. So when they have an abnormal GTT, I think then we can start metformin. And if she has already not on, she started on metformin, I wouldn't be very happy continuing metformin. I will ask her to stop the metformin for a couple of weeks, do a fasting blood sugar and a postprandial blood sugar if she's having excess vomiting, or straight away do a glucose tolerance test along with the HbA1c.
Dr. Binu asked.
Sorry, madam.
Yeah, continue, Karpagam.
Regarding progesterone, actually, progesterone, if it's been started as a part of corpus luteal defect and intrauterine pregnancy has been confirmed, we may continue till fetal heart is seen. But apart from that, routine use of progesterone for obesity is not recommended.
No, the patient was not put on progesterone because of obesity, but because it was an ovulation induction cycle. Yeah. Then the patient was put on progesterone, and which definitely we will continue till the placenta takes over the function. Yeah. Dr. Binu, as a neonatologist, what are your opinion about a patient being on metformin in the first 3 months of pregnancy, which is a period of organogenesis? Because there are conflicting reports from an endocrinologist. Many of them are not happy about metformin, whereas some of them say metformin is very safe. Are you quite happy for the patient to continue metformin in the first, say, 12 to 14 weeks of pregnancy?
Personally, I have not had any issues with mothers who have been on metformin at all, though I know the conflict is there. And I really don't have a worry about congenital malformations because of metformin. No.
Thank you. Now, so Shanti, would this lady qualify for low dose aspirin now?
This patient, see, she is obese, and she is actually 33 point something is her BMI. So according to our Asian listing, it will come 31 to 35 is class 2 obesity. So when we see the Foxy-Gestosis score, then this obesity warrants 2 points. She being primigravida, 1 point. So, and she is also having PCOS. So I think when she has 4 points, I will put her on aspirin.
Karpagam, do you have, will you do 11 to 14 week scan, ask for a preeclampsia screening, and if the patient comes high risk, would you then start her on aspirin? Or at 8 weeks when she comes to you for antenatal booking, would you start her on aspirin?
Madam, for this patient, actually, as Shanti Madam said, she fits into the criteria for high risk for preeclampsia, as per the Gesture score and also the BMI. So definitely, she is a candidate for. Actually, we give ecosprin or aspirin 150 milligrams usually, madam. So we don't go by this low dose of 75 or 88. We go by the 150 milligram of ecosprin even before the preeclampsia screening. See, all the guidelines in US or UK, they start their booking scan by around 11 to 14 weeks. So they they actually start ecosprin or aspirin around 11 to 14 weeks. But most of our patients, we see them by around 8 weeks for a viability scan. So once we see that, I think I will put her on a ecosprin 150 milligrams, madam.
Okay, so as both the panelists said, whenever the BMI is more than 35, first pregnancy, maternal age of more than 40, family history of preeclampsia, so they qualify in order to, as a prevention for preventing preeclampsia, the patient was started. Now, Shanti, you did 11 to 14 week scan. The baby is growing, but her Down syndrome screening result comes as an intermediate risk, as to 1 in 440 for Down syndrome. Now, how will you counsel the patient?
1 in 440 is intermediate risk. So probably this is done in 11 to 13 weeks, 6 days scan. So probably another additional thing can be done around 16 weeks. For such patients, generally we offer NIPT. But then for obese patients, NIPT we cannot offer because there are less chances of fetal cells being seen. So because of all these things, NIPT might not be very useful. So probably another additional thing at 16 weeks, adding maybe estradiol, all these things, it can be done. If nothing works out, the counseling for amniocentesis, I do not know how far it will go, but then that option also, at least, it should be told to them. I would not consider it as mandatory, but then I would rather give another option of doing it at 16 weeks with other factors. But then this also should come up during counseling.
Karpagam, when we talk about sequential screening, as what Dr. Shanti is telling, now we know that the first trimester screen has got a better sensitivity than doing a quadruple test at about 16 weeks. So what is your take now? She is 35, has had an infertility of 8 years, and she would like to take home a healthy baby. You do a test and you say, look, you've got an intermediate risk. So how will you counsel this patient?
Yes, madam, because now the latest softwares or the reports, they don't give the intermediate risk. But we know that anywhere between 1 in 251 to 1 in 1000 can fall under intermediate risk. I will sit with the couple and counsel them that obesity or high BMI can actually alter the values of this beta gene PAPE and skew the results of the first trimester screening. So that is the reason why in all the prescriptions that we write, when we fill the forms, we have to calculate the BMI and send the patient, because the software has a special correction for that. And for this couple, I would like to tell them that, now it comes in an intermediate risk, but we might get and do an early target scan. So the early target scan, as madam said, we can do between 16, 18 weeks. So if there is any soft marker that is seen during a early target scan, I would tell her that, better to go for an amniocentesis, because definitely that will be more beneficial. If in case NIPT can be done at any gestational age. So as the gestational age advances, the cell-free fetal DNA fraction actually increases. So when we do it at that time, if for example at 18 weeks the early target scan is normal and there are no soft markers, I would tell her to get an NIPT at that time and reassure her that 99% the chances of the baby being normal.
See, you both clearly pointed out in an obese patient, we can get a completely negate, we might not get the fetal fraction, so that it might negate it completely. And Dr. Shanti also pointed out that when you write out first trimester screening, then everything has to be included, because it is just not the test, supposing it comes as negative and positive. And if you get an intermediate risk, then it has to be followed up. And you also, quite a few times when you send them for scan, you might get a report saying that because of the obesity, the clarity of the sonography is not good. So all that have to be taken into consideration. Both of you brought out the points very well. She is currently 20 weeks. Her weight has gained from 84 to 89. So during the target scan, Shanti, do you routinely ask for a fetal echo? Are you quite happy with the 4-chamber view? And then if the sonologist suggests, then you go for a fetal echo?
Generally, a 4-chamber view would suffice. But then she being class 2, she's in class 2 obese patient.
Class 1.
No, because as per Asian this thing, she will come under class 2, okay. 31 to 35. So in that event, the chances of congenital anomalies are also more, especially cardiac anomalies too. And we have a chance of missing them also because of the maternal obesity. So because of all these things, I would probably do a fetal echo, probably around 21 to 22.
So that point was well brought out. If you ask for an early target scan between 16 and 18 weeks, because you want to reassure yourself and the couple, then it may be very early to pick up all the anomaly, and hence you need to follow it up with a scan where the sonologists are quite comfortable picking up all. So now you have done a GTT. The results are 104, 196, and 156. You had actually stopped the patient, metformin at the booking. Her blood pressure is normal. She is 20 weeks. Karpagam, how would you manage this lady?
Now we definitely have a situation where she has 2 values abnormal. So she falls into the category of gestational diabetes mellitus. So now we have to address the issue of, even then we would have advised about good diet and exercise, being active during pregnancy. Now we will give her a medical nutritional therapy about GDM for the first 1 week to 2 weeks. Ask her to maintain a CBG log. That is very important. Most patients, when they monitor sugars at home, we will be seeing very erratic values. Then we will always get an endocrine opinion or a diabetologist opinion regarding management of gestational diabetes.
Very beautifully said. Now she is managing well. She is following a diet, but she is very scared to do any exercise. People have told that she has conceived after 8 years. So limited activity is better. So how much ever you say, she's not very convinced. Currently now she's 92 kilos. On a diet, fairly good control of sugars. The scan shows the AC on the 75th centile and polyhydramnias. And her BP has slowly crept up to 140/90. Shanti, she is with you now. And whom all will you involve? And how would you take care of this patient now?
Yeah, 1 BP, 140/90. I will just repeat it probably after 4 hours, after she's quite calm. And then if it shows 140/90, then I would do all blood parameters. Especially LFT, RFT, and a CBC, all that I will do. Then I will put her on labetalol right away, because 140/90, our target should be 135/85. So I would put her on labetalol, probably 100 milligram BD, and then watch her. I think Anyway, because she is obese also, I would have got an anesthetist opinion, intensivist to see also, because she has more chances of going in for section, or during labor also, she might have shoulder dystocia, some tears, all that. So I'll be very scared. So I will ask my anesthetist to actually ask my patient to visit my anesthetist also earlier itself. But otherwise, I think these I can manage so far with Lebitlol 1 BD, 100 milligram BD.
And you would also carefully look at her sugar control, because there is a little bit of a polyhydramnias.
Yeah, polyhydramnia shows that it is not under control. And she's slowly creeping through to macrosomia too. So that shows that it is not. So I will talk to her more, talk about maybe upper arm exercises, which will really be beneficial for her baby. All those things I would probably reiterate.
There are two of our panelists who are quietly sitting, Dr. Vennila and Dr. Raj Palniappan. So as Dr. Shanti Gunasingh rightly said, Dr. Vennila, this is a patient who is booking with you for delivery, and then her weight has crept slowly. It has increased from 84 to 92. And she's also developed gestational diabetes and gestational hypertension. And at this time, she is 28 weeks. Ideally, at what gestation would you like to get involved? And what is your advice for the obstetrician?
Good evening, ma'am. It's a very interesting patient, and it seems like we see one of these kind almost every day in our practice, being a high-risk center. I mean, ideally, sometime in the second trimester, as soon as they recognize that there is a problem and there is a persistent weight gain, then the obstetricians usually ask us to have a look, as you rightly said, so that we are aware of her in case she comes in preterm labor. We have already seen her, and also if we can have an opportunity to pre-optimize her. As physicians involved during the care, we can actually advise on any particular issues. So considering this lady is obese, she's having a precious pregnancy. There is always chances that they have accelerated hormone status. With all the pathophysiology that we've learned from Bharani, we know that she may well have an inherent tendency towards hypertension and diabetes, which we probably would have anticipated, and that's why she's on aspirin. So now our aim would be to have regular control of blood pressure, proteinuria. What is her heart status like? What is the status of weight gain? Is her weight gain quite accelerated, like 1 to 1.5 kg a month, or in the last week has she gained 1 weight? That sort of an acute weight gain, acute shortness of breath would give us an idea that the fluid retention is not going in the right way, and the physiology is not good, so it's becoming pathology of pregnancy. Then we know that there are some red flags. So usually if they have shortness of breath, maternal tachycardia, BP, which is persistently high with or without proteinuria, and as Shanti Madam said, our LFTs and RFTs would give us an idea which way we are going as well.
So would you routinely ask for an echo and an ECG in all these patients, or only when you clinically suspect something, you will ask for it?
No, ma'am, I think ECG, we ask now routinely. I mean, she is 30 plus. And in the current generation, I mean, over the last 10 years that I've been here, we see that there are more and more reasons to ask, because women are having weaker hearts, and there's a tendency to go towards cardiomyopathy in this particular lady with both systolic and diastolic dysfunction. So we will ask for an echo in second trimester. If status quo until delivery, we don't repeat. Unless something changes just prior to delivery, then we will do a bedside echo. I think most of us are now familiar with doing the bedside echoes, and that would give us an idea whether she's progressing well or not.
Shanti, what happens in institutions? Is there a government policy to do an ECG and echo in all pregnant women, or only when you consider them as high risk, you will do an ECG and an echo?
In corporation, they are doing routine ECG and echo. That is, earlier, long ago, they lost a few patients, knee-jerk reaction. After that, routinely it's being done. In IOG and institutions like IOG and KGH, that is not being followed. But if indicated, it is being done. But corporation, they routinely do.
At what gestation it is being done in the corporation?
Second trimester.
Second trimester.
Yeah.
Now our lady has come to 34 weeks. Her blood pressure, despite labetalol, is currently 150/100. Thankfully, there is no proteinuria. Her blood sugars are reasonably under control with diet and metformin. She is still not on insulin. Now, Dr. Binu, when this kind of a patient is presenting to you, at what stage you would like to get involved in this care?
I usually get involved only when the obstetricians are contemplating delivery, because there's no real role for me before that. And usually the question comes in as a nearing term, should I give steroids? I've already given steroids, should I give steroids again? Otherwise, there's nothing really for me to do at this stage. I will wait for you to tell me I'm going to deliver the baby.
So, Shanti, would you steroid this lady currently, right now?
This patient, 34 weeks, she's already 34 weeks. And I think the dose of labetalol probably can be raised. So I would rather increase the dose of labetalol, and I do not think I will repeat all investigations, and then if everything is okay, I don't think I'll be steroiding her right now.
Sure, because you're not planning delivery for her right away. So giving steroid unnecessarily, which will make her blood sugars control go little this way, that way, we are not contemplating. So now, Karpagam, this lady, would you deliver her at 37, 38, 39? Or would you induce, or would you rather do an elective cesarean section?
Considering the fact that she has both gestational diabetes mellitus and as of now it's gestational hypertension, not sure if she has become a pre-eclamptic by 37 weeks, because till 34 weeks her proteinuria was not there. Now we do not know the proteinuria now. So still I would definitely like to induce these patients by around 37 to 38 weeks if all the parameters are normal. Because the most important thing we need to understand in these where there is a combination of both preeclampsia and diabetes is a lot of times these people they might not get into labor on their own, and definitely they will be better off delivering these babies when they reach term rather than getting into complications maybe after 38 weeks.
So there is always, sorry,
madam, would you induce or elective section? I definitely would like to give the option of induction to her, because for all practical purposes, for her own good sake, normal delivery with an appropriate gestation weight baby will be the best option for her. I definitely would like to give the option of induction of labor rather than going for a planned elective cesarean section.
So Shanti, maybe because she is 35, married for 8 years, conceived after infertility treatment, and she is a gestational diabetic from 5th month, gestational hypertensive. So what are your views on induction versus an elective section?
No, I would induce her. And vaginal delivery, first I will assess the baby. I will see what is the weight of the baby now, all those things, and whether her pelvis is adequate. Because sometimes if the baby is too big, then probably that is a different matter. If not, I would always induce the patient, and vaginal delivery is any day much better and safer for her than a C-section.
Very seasoned obstetricians coming up with lovely answers. Now, what are the anesthetic challenges, Vanilla? When, that lady says both Dr. Shanti Gunasinghe madam and Dr. Karpagamal madam told me to go for an induction. but I'm very scared and I've never walked throughout my pregnancy and I've got all kinds of complications. And in a way, we as obstetricians are also happy because we can do it in a planned way, rather than getting caught with a 92 kg patient in an emergency section. So what are all the anesthetic challenges and what would your advice be to us?
Yes, yes, ma'am. I think the challenges can be right from the airway. Even if we're thinking of anesthesia per se, when if she comes to section, but if we are planning for an induction, the most ideal would be to place an epidural early for her, because the chances are, if there is an altered anatomy and a very anxious patient with a very precious pregnancy, things get very complicated, and once the pain sets in, well, so early epidural we can counsel for her. So there are chances that we will get it in anatomically well. If not, ultrasound guided epidurals can be placed. And once the pain sets in, we can slowly increase the dose. We have to be cautious about the volume of dose given in boluses, because they can actually drop the pressure very fast and that can induce fetal distress. So it has to be very tapered, slow infusions monitored by the anesthetist who's there, so that we can actually monitor the blood pressure and we don't have a sudden fall that compromises either the mother or baby. Chances of failure can be high, but in the good hands, the skilled hands, and in the with ultrasound and the right needle, it should be successful, and that will give the patient the best chance for delivery, especially if the first stage is prolonged and they are going to get tired. So that would be the most ideal if she's coming for induction.
Your point is well taken. Trying to find a vein in an obese patient when she's screaming and shouting is going to be very difficult. So being prepared is always better. Now, what are all the challenges during a cesarean section, Karpagam?
So the most important thing I would like to tell you is, being obese, the patient can be very sensitive to the fact that she is obese. So most importantly, all the entire team has to be very sensitive, and including the theatre gown, aprons that are given to her, everything has to be double XL size. And we call them, it's actually a lot of times some hospitals don't have these special big sizes, XL, double XL sizes. And patient, if we give them a smaller one, they may feel very embarrassed and they feel very bad actually, because the gown is not fitting them. So I always tell them, when an obese patient or with high BMI patient comes, please make sure that you arrange all these things, including the cot, the bed, including the BP cuff. We call them actually manual handling equipments, and we need more hands to shift the patient from the trolley to the theatre bed. So all these things have to be taken care of during cesarean section or during shifting the patient. And as Dr. Vanilla said, sighting a line is actually very challenging. I always keep telling patients, please drink lots of water, because otherwise it will be very difficult. We might have to use an ultrasound to get a vein for you. And sometimes they might put in the cubital fossa, which will be very difficult for you to feed the baby after delivery. So many times the dorsal veins are not visible. So please, I will ask them to hydrate themselves well. This is manual handling equipments. It's very important. And please, we should not make her feel embarrassed during the procedure or during shifting that, and all the team members should be very sensitive to it and not utter any word that is going to hurt her. And regarding the procedure, as Dr. Vanilla said, citing a spinal or an epidural can be very challenging. So that is one aspect which she had mentioned. And regarding this surgery as such, we need actually 2 assistants to help us, because sometimes the abdominal flap can be really thick, so that we have to somebody has to hold the flap, raise the flap and hold it. Then during the delivery process as such, the head can be very mobile. We might have to use instrumental delivery, and going deep into the pelvis and doing a suturing can be tricky. So the entire team has to be tuned to be ready to operate on such patients with good alertness.
Super.
Just one thing to add, ma'am, about the timing. If she's on Clexane for whatever reason, because some of them, especially if they were assisted reproduction, they may well be on Clexane or 150 milligram aspirin, then we have to time accordingly our neuroaxial anesthesia and the dosage of antibiotic based on the weight, rather than just a standard dose, because under dosage has been commented as a significant reason for surgical site infection.
Now, Dr. Benu, would you like to, you took us through the care of the problems with the newborn in the form of transient tachypnea, respiratory distress. But then if you are going to deliver at 37 weeks, do you expect any problem in the care of the newborn, or generally they pass off as normal?
Right. So babies born to mothers who have got diabetes would often tend to behave as if they are around 2 weeks earlier. So if you're born at 37, they still behave like 35. In reality, this baby, the story that you told me, to this mummy, would invariably mean that the baby will be in the NICU until I'm absolutely sure, at least for 5-6 hours, that baby has no respiratory distress at all before I hand over the baby to the mother. The second major thing is that one is TTN, of course, if not RDS. The second thing is establishing feeding. There is going to be a huge failure rate of breastfeeding in this mother. And it is not going to be easy counseling her and getting her to feed. So all these reasons, I would tend to possibly have the baby with me, keep shifting the baby to the mother to feed, establish, and then hand over the baby to her.
That's very beautifully said. Now, Shanti, we as obstetricians get to see these obese patients every month. And at every opportunity, we keep telling them. But during the postpartum, a word about thromboprophylaxis, I'm sure everybody knows. Now, post-delivery, she comes to you for review at 6 weeks. What tests and what contraception?
Shifted. Before giving one Sona ma'am's patient, ma'am. Second last patient, I think, some Medinexal mass. Shanaz is giving some amount of bleed was there. BP is 90-60. Heart rate is
Vanilla ma'am, you have to
Sorry.
Vanilla madam's thing, yeah.
Sorry, ma'am.
Yeah. This patient, see, because she's a GDM, she needs GTT at 6 weeks. So that I would have counseled earlier itself, so that she comes at 6 weeks, when she comes for checkup, well prepared for that. So that is the most important. And I would also talk about contraception, and all these obese women better not to give hormonal contraception. It is not a contraindication as such, but it increases the chances of their thrombosis. So I would probably choose other things. I am very fond of long-acting reversible contraception in the form of IUD, or so I think I would choose that.
Yeah, putting an IUD for a 92 kg patient is going to be quite challenging as well. Now she comes 1 year later. Now her weight has actually increased to 98 kg. She is very depressed about her weight. She says this baby was born after so many effort, but I'm not able to take care of my baby because I'm breathless and I also have low back pain. So as a primary care physician, Shanti, what are your views on bariatric surgery?
I mean, it is our duty to offer whatever's in the horizon for her. So probably I would send her for one consult to Dr. Rajkumar.
So shall we get Dr. Raj Palniyappan involved in that? So Raj, now she is 98 kg. Is Dr. Raj still there?
Yeah, I'm there, doctor. Yes.
So when they come to you, many a times they would not want a surgery. Many a times, whether even if the patient wants a surgery, her relatives and family members would say you're doing something unphysiological. So, how do you actually convince them to undergo a bariatric surgery? Or is it that they maybe morbidly obese patients may come and ask you, but majority of them will be in that, where they are not sure. So how would you counsel them?
Okay. First thing first, doc. So going through the history, she had gestational diabetes, hypertension, as an aspirin and metformin, and post delivery, first 3 months. Now normally they will lose weight, and which they might be able to manage a little bit. But then beyond 6 months, they will start gaining weight after pregnancy. But here she was 84 when she got pregnant, and now she is 98. A BMI of 7% should, which is not very easy for her to lose now. And with so much of a steroid and other things with metformin, which couldn't help lose weight and increase her, increase her weight, she might be in a better situation to tackle it non-medically. I mean, beyond medicine or with some medicine, if possible. Unfortunately, the only medicine which can help her is what you call semaglutide. So we might offer her initially medical management with semaglutide for a period of 3 months, which is a GLP-1 analog. As her weight is 5'2", they say BMI is not alone the only reason that could define one's complications of obesity. The height is a major factor as well. A shorter person with a low BMI is as good as a tall person with a super obesity as well. So with a 40 BMI right now, she's as much as a 50-55 BMI of a 5'6", 5'7" lady. And with already a lot of issues with her, I will try to convince her for a much more weight management and longer duration by means of surgery if possible. If not, by means of medicine. I will not prefer a balloon because balloon is a stopgap. If she is not getting pregnant again, if she needs to do some weight loss, then balloon can be tried for a short while. Otherwise, I will recommend medical management to start with and convince her for surgery, giving reasons about diabetes, hypertension, dyslipidemia, and as well as with breathlessness now, OSA is on the horizon. With all these things, she's going to be much more difficult to manage her activities, which is going to maintain her weight loss if she loses weight well. So with all this in mind, I will recommend that she will undergo bariatric surgery. And USP what we will use here is, if she want to get pregnant again, her chance of pregnancy is 70% if she undergoes bariatric surgery and wait for another couple of years. One. Second, the gene expression of a baby changes if you do bariatric surgery. So they can have a genetical breakup of not having an obese child because the expression of the genes can change as well. And she might be a much more stronger chance of becoming diabetic and hypertensive and eclamptic in the second one if she is already 92. So with all these things in mind, if she is willing to go for a second pregnancy sometime later, she have a window of another 2 years easily, because this to have a first child is only 1 year. This is a very good window for bariatric surgery. So these are the ways I will convince them. And of course, the results of 85% resolution of excess weight, 95% resolution of comorbidities are going to be there in our armamentarium to help her get convinced. And of course, the biggest convincing power has to be for the relatives who say it is against nature and why to go under the knife. But of course, we have laparoscopic technique nowadays, robotic techniques nowadays to help convince them that just a matter of 1.5 hours you'll be able to manage it. With the recent addition of metabolic surgeries, with least amount of issues like vomiting, nutrient deficiencies, being able to manage very easily now with a good support system, what we have in case of supplements, we will be able to convince these kind of people very easily. Actually, these kind of people they come to us much more than before. Nowadays, more than 10 to 15% of our patients are all 6 months, 1 year post-pregnancy ladies who are not able to manage themselves anymore.
Thank you. And you said that one has to wait for the weight to normalize, maybe between 1 year to 1.5 years before they plan for a pregnancy. You told that. And you also talked about the nutritional supplementation. My only question to you is, are these women more prone for babies with growth restriction?
Intrauterine growth retardation is not that much reported, maybe one-off cases here and there, but small for gestation age babies are pretty common. especially when they are not supplemented well enough. So over-the-counter supplements are not good enough for these people. They need to have a bariatric specific supplementations for sure, which are all 10, 15 times higher concentration and easily dissolvable supplements and easy salts, which are going to have good bioavailability over-the-counter drugs. So blank recommendation is go for bariatric supplementation if you are post-bariatric during pregnancy, and assess them every 3 months. If necessary, we'll give injectables also every month or every quarterly, depending upon how they respond to the oral supplements. If you do this kind of a nutrition supplementation, you will have a very good gestational growth weight of the mother, as well as reduce the small gestational age babies by 90%. So they can be as normal as any other non-obese pregnancy. So this is all very important. But for these two, SGA babies are very common. And of course, if the deficiencies become so severe, B12, calcium, iron goes very down, calcium and zinc and all goes very down, phosphorus, they will have a IUGR at some point of time if we don't take care of them well.
So the point that I get it is that the bariatric surgery patients have to be managed in consultation with the surgeon who did the surgery, so that they are adequately nutritionally supplemented, so that their babies are appropriately grown. Because
and one more addition to the point is, doc, not all bariatric surgeons supplement their patients with the bariatric supplementation. So from the obstetrics point of view, I think recommendation is a bariatric supplementation. If an obstetrician is well versed with managing a post bariatric pregnancy, they can very well prescribe them bariatric supplementations, which is available across the counter. However, at least a quarterly consultation with a bariatric team, a nutritionist, bariatric nutritionist or a surgeon, to understand whether the nutrition supplementation is good enough is very important, especially when it comes to parameters like calcium, protein and all. They will look normal in the blood parameters, but they are deficient in their muscle very badly. They are deficient in their bone very badly. So for these reasons, just the biochemical value alone is not good enough. Their body composition analysis is very important to understand the nutritional status of the patient. That is why a bariatric consultation is very important. Depending upon the body composition analysis, we change the nutrition supplementation irrespective of the blood parameters.
Raj, we need to have one more session, because quite a few of us manage just one bariatric, post-bariatric surgery in 6 months. So, many of us are kind of not very aware of it. So we'll ask Rajeshri to have one more session. We are actually coming to the end of our time. It's going to be nearly 6. So I would like to just thank all my panelists who did a wonderful job. And I couldn't, distribute the questions because initially we had to manage them through pregnancy and then bring in an anesthetist and the pediatrician and the bariatric surgeon. I really appreciate all of you for staying so long very patiently. And all these have been discussed by Bharani in the first slide itself. We know that compared to a healthy pre-pregnancy BMI, all these are increased. So if I ask all my panelists for one take-home message to deal with this pandemic of obesity, so I will start with Dr. Shanti Gunasinghe. And with that, we will finish our panel. Shanti, unmute yourself.
Sorry. I think our care starts from the womb. So our antenatal care, actually the woman of next generation, now itself we have to start caring for her, so that we have an optimal weight gain during this pregnancy. We make them exercise quite well, be aware of the proper nutrition, so that an appropriately grown baby, not too small or not too large, is born. So the proper seed is sown now. Then after that, we have to continue through adolescence and later too.
Karpagam.
Yes, madam. Actually, there, as Shanti madam said, there is a lot of insight into fetal origin of adult diseases, not only metabolic diseases, most of the other diseases as well. So I think we have to actually invest more on healthy and fitness, healthy living and fitness. So diet and exercise actually goes a long way in actually planning a better future for the next generation kids.
Karpagam is a fitness enthusiast. You can see all the running in marathon and things like that.
No, I'm not doing for the past.
Vanilla.
I have to start again.
Vanilla.
Yes, ma'am. I think the point is well taken. I think we have to take care from the children, prevent childhood obesity, so the future generation is better. From the anesthetic perspective, once we identify a at-risk patient, we have to prevent the aggravation of risks. I think that's where we have a role from the time we see the patient. So we don't just take them for granted. Like most of the data is Western. This doesn't apply to us. We cannot ignore it that way. We are getting more data from our country, our population as well. So we have to be warned that they can throw surprises at us and keep our guards on.
Dr. Binu?
Madam, my take-home message would be that the intervention should start pre-conception rather than in the womb. Because as I said, all the epigenetics and everything is pointing towards that an altered scenario is what goes on for future adulthood problems. So the health education and the generational obesity should be broken somewhere.
Raj, can you invent some anti-obesity drug rather than these surgeries?
It's pretty difficult. If I do that, I'll be the richest man in the world.
You can get the patency.
Yeah. Having said that, if a woman is waiting for pregnancy, the best way is meet a qualified consultant to understand your body composition, get the right kind of a diet and activities. High protein, normal fat, low carb diet is the way, and especially intermittent fasting is the way for a thrifty gene. So we work on these kind of ways to lose your weight so that you help. If that's not helping, short-term goal of medicine or a balloon to help yourself to get to the pregnant status and get you pregnant. Worst come worst, you are morbidly obese, super obese, then our services are there. When you become pregnant, I always say, make sure that you will not gain beyond 6 to 8 kilos, because there are enough studies to prove 6 kilo to 8 kilos weight gain is enough to have a 3.5 healthy baby. But then again, that has to be with a high protein, low carb, normal fat diet. Unfortunately, we have a high carb diet, and the 6 kgs what you put, 4.5 kgs is going to be with you, and only 1.5 kg is going to be the baby. So this kind of a diet changes. Instead of telling that have a healthy diet, we plan the diet accordingly. And at the end of the day, if you are not healthy and if you're obese as a gestational mother, you are passing that bad gene to your child, and you are giving a child another chance of becoming an obese childhood, obese adolescent, and with the PCOD, menstrual irregularities, you are giving them a lot of trouble as an adult as well. So you have to be responsible to yourself, to the child, at the end of the day, to society as well.
So, Rashri?
Yes, ma'am.
We want to be on time.
I want to offer my thanks. First of all,
I'd like to thank my panelists.
Yes, ma'am, I'll do that.
Every one of them for very, staying patiently. It's a working day. I know every one of you have clinic to do. And I would like to thank Dr. Shanti, Dr. Karpagam, Penila, Dr. Binu, and Dr. Raj, and the Safe Motherhood Committee for giving us an opportunity to be with you. Thank you.
Thank you.
My pleasure, and to thank you all. First of all, I would like to thank Almighty for the successful conduct of this CME. Our President, Dr. Jairani, and Secretary, Dr. Kundavi, Oxy, for giving us this opportunity. I would like to thank, first of all, the first speaker, Bharani. She started well. starting well means half done. It was a kickstart by you, Bharani. Then we had Dr. Raj Palniappan and Dr. Binu sir, who readily agreed to come into the panel, and they took their time off to share their knowledge and experiences with us, which was really very enlightening for us. And then we had the very interactive panel. Nirmala madam, you brought out, as you said, you had to cover a lot of them. You had to include our obstetricians, you had to include neonatologists, anesthetist and bariatric surgeon, and you did an excellent job of covering the entire thing and giving a good take-home messages. And yes, all the panelists I need to congratulate, because you were specific on what needs to be done, and we all had a very good take-home message. Thank you so much for sharing your knowledge. I'll be failing if I don't thank Nitya. It was a very well done mock, and also Shield Pharma for the excellent tech support. We didn't have any hitch, and it was really great. Once again, I thank you all. I thank you all. Thank you so much.
Thank you, everyone.
Thank you.
Thanks for the
Thanks to our
opportunity.
moderator.
Bye.
Thank you, thank you, ma'am. Thanks. Thank you. Thank you. Bye.
Thank you. Thank you so much. Thank
Bye.
you.
Bye. Bye. Thank you, Rajshri. Thank you, ma'am.
Thank you, ma'am. Thank you, Shanti ma'am. Thank you so much.
Bye. 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 Bye.
Chitrakala, we are done.
Yes, ma'am.
Thank you so much. Thank you.
Thank you so much, ma'am.
Thank you, ma'am.